Well, hello and welcome to another episode of Coffee Talk with Encore. Today, we will be discussing the upcoming MDS changes that are on their way starting on October 1st. Well, every April, we wait to hear what changes CMS has in store for skilled nursing facilities, and this year was no different because CMS has released a draft of the fiscal year 2024 final rule, which did include many updates and changes. Now, today we're going to be walking through some of those proposed changes and how they will affect us this coming fall.
Indeed. All right. So many of the new changes are really focused on, that health disparity. So I actually read a really interesting article put up by McKnight's, and it really just kind of says that CMS is really committed to achieving equity in healthcare outcomes for all of the beneficiaries that they are serving. So the questions are going to focus on ethnicity, health literacy, language. So if your patients in your facilities need a translator, making sure that that translator is provided appropriately, any transportation for appointments, and then there's also some verbiage in there for medications to be transferred to a subsequent provider. So the goal of the questions are really to ensure that all the participants are receiving the care that they require. So as healthcare providers, it's really important that we use this information to help CMS track for future needs for our patients that we're serving, use this information in care planning, of course, ensuring equity or inequality for all patients that we're serving. And it's really critical that we handle these questions with care to make sure that we are allowing our patients to answer these questions accurately and dependably, so they're comfortable communicating what their needs are.
Good points, Ashley. We are also going to see some changes with the interview process, starting with the PHQ-9. So this will potentially be a shorter process, starting with answering only the very first two questions as more of a screening tool than a full assessment. So if our patients answer either more than half the days or nearly every day, so a score of a 2 or a 3 on either of those first questions, we're going to move on to do the entire rest of the 7 questions in the full PHQ-9. If we don't get those responses, we will just stop at the first 2 questions and move on. And now it does seem like this might be less work. That's really great. But there are some factors here that could get a little tricky. So first, if our patient doesn't know us well, they may be a little bit hesitant to answer those questions honestly. We're asking questions about feelings, how they feel, and essentially, we could be strangers talking to them. So we might miss out on an accurate picture of how they're really feeling. And secondly, it really puts more of a responsibility on us as caregivers to identify when our patients are having some delayed healing and what's going on with that. So are they having decreased food intake? Are they having pain? Are they having poor sleep? How is their mood? And how is that affecting their outcomes? And lastly, it could have a financial impact on the facility. So when we fail to identify patients who are having issues with depression, we're missing out on about $20 per day for those patients because they do require the extra care. So we do get reimbursed for that. So it's really important that we find a method that works for us, that works for our patients, for us to make sure that we are getting good answers for those first 2 questions in order to not miss out on those needs of our residents. The second thing that we are seeing when it comes to interview changes are the BIMs on discharge. So they're going to be looking at what is their cognitive score, and are we sending them to a location that is safe and appropriate for that cognitive score? So, if they have a cognitive impairment, we probably shouldn't be sending them home alone. So things like that, just making sure that we're doing our part to make sure that our residents are safe on discharge.
One of the other really large changes that we're seeing from CMS, and it's kind of a move across all the continuum, but we're standardizing that functional assessment for our patient. And so we're seeing that final transition away from Section G, which was traditionally filled out by our nursing assistants with their daily flow sheet coding. And we're moving formally into Section GG for all of those measures. So as therapists, I know a lot of us have been filling out Section GG in the past. You're going to see that there's even more line items because they had to move some things over from Section G that previously weren't included. From a facility standpoint, we have to make individual decisions of, are we going to change the way that the nursing assistants are coding on their flow sheets, the way that we're capturing that information? Are we going to go through all of the education on those new coding terminology and looking at the activities? They don't necessarily correspond. So when you look at dressing for section G, it's kind of an all-encompassing activity. When you look at it in section GG, it's 3 different activities. So we're really going to have a lot of training if we're going to change the way that the nursing assistants code that information. Additionally, we have huge implications for our quality measures because there was a lot of quality measures that were using section G either directly for their data or for weighting and modifying that denominator for our other quality measures. So when we were looking at risk factors and whether a patient should be or shouldn't be included in the item set. And the last piece of this is our Medicaid case mix. So many of our states were still using a RUG-based system for payment. And so they were using that RUG ADL score, which is based off of section G. If the state doesn't choose to adopt the PDPM system, then all of those quarterly annual OBRA assessments are now going to require that the MDS coordinator submit the OBRA assessment for Medicare and for the CMS system, and a second OSA or optional state assessment for that state case mix system. So it's going to be a lot more work if the states don't move to adopt that PDPM system. And so we're really watching each of those states individually right now to see what's going to happen.
Definitely interesting information for sure. And gosh, there are so many changes. We definitely need to be aware of all of this as we move forward and get closer and closer to October. So in addition to all that we've already discussed, there's also going to be some new additions to MDS assessment on pain. There's going to be some new pain questions included. Now, the focus of the MDS pain related items are going to be related to how pain interferes with day-to-day activity, how specifically it interferes with therapy as well. So we're really going to need to make sure as a therapy perspective to know how important it is that we are communicating any concerns with pain to nursing and MDS. We need to make sure that they're aware of issues and they can make sure that we've got that communication system set up so that the patient concerns aren't coming to as a surprise to nursing after it's either too late to address them timely, or even to make sure that those patients' pain details are then being included in the MDS assessment. So therapists, we need to make sure that we're conveying that information, prior to that patient interview that's being done by MDS coordinators, so they can include that pain information within that MDS assessment. Now, another change that we're seeing come our way is related to section K, and that is the swallow and nutritional status section of the MDS. And with that, nutritional approaches that we are using in therapy, we need to, again, make sure that those interventions are being communicated to nursing so that we can get that included in the MDS as well. Well, it's also important that we're capturing nutritional approaches then at the time of admission. And that look back period is the first 3 days of the patient's stay. And that also MDS coordinators then able to capture those nutritional approaches at the time of discharge. And that look back period is the last 3 days of the patient's stay. And so we want to make sure that, again, we're communicating all this information to nursing and to MDS, because what we're doing in therapy, we can't be in a silo. We absolutely have to communicate this information because of all of that it can impact for the patient's stay and for reimbursement for the facilities, to really just to get reimbursed for what therapy services and what nursing care services we're providing those patients who need it. Another thing to think about is speech therapists. They can certainly make a difference in coding mechanically altered diets as well as G-tube use for nutrition. So a lot of things for us to be aware of for sure.
Now, one of the smaller changes when you look at the MDS form itself is in section N. And that's when you're listing off some of the medications that the patient is on. And the first change is that CMS changed the wording of that section. It's now listed as high risk medications. And so these are our antipsychotics, our pain medications, some of those really complicated medications that we see being high risk for that geriatric population. We changed the name, which seems mild, but then they added a checkbox for notes indicated in the chart. And this really comes down to us supporting that documentation that we didn't put a patient on an antipsychotic because we were tired of listening to them, right? So we're going away from putting the patient on a medication and just forgetting it. And we're double checking to make sure that that information is still in the chart to support that that patient still needs that medication, has the appropriate diagnosis to back it up. And what's a little bit scary about this for me as someone that watches kind of the regulation and what's going on is we've seen that the MACs are already starting to audit patients who have schizophrenia diagnosis and medications for schizophrenia. And they're really diving into those charts. And they're saying, if you don't have the supporting documentation, you're going to lose that schizophrenia diagnosis on your MDS, and then you're going to get hit on your quality measures for providing those medications without the diagnosis. Now, we're seeing this for schizophrenia, but schizophrenia is one of those medications that's listed on that high risk. So I'm anticipating the chance for the survey team and for the MACs to start looking at those other medications and diagnoses and diving into all of those in the same detail. Additionally, we see in section O, when we look at documenting our IVs and our chemo meds and our radiation meds, things that we get extra nursing money for, they're now looking for a little more detail as to what type of IV site we have, what type of chemo medication we're getting. Is it IV? Is it oral? And so I'm wondering if in the future we're going to see some financial implications for those different types of medication. Are they going to change the way that those work in our nursing categories?
Well, and along those lines, while we're still waiting for that final legislation, both at the federal level and for many states at that state level, it's truly going to be important for facilities to begin planning now for these changes that are coming our way in October. Care planning and documentation, it's going to be critical for the new survey process. We need to make sure that we are, discussing changes with nursing, making sure MDS is aware. We need to make sure that we're detailing specifics of patient care within our documentation, that we are care planning, and that we are discharge planning. It's certainly important to the MDS assessments because we have to support that documentation by using documentation, everything that's within our MDS assessments, because it will be reviewed potentially by CMS. And it's important that we have everything in place to support what we're coding on our MDS assessment. It's important that facilities put these systems into place because we want to avoid negative survey findings. We want to make sure that we're, addressing any changes in quality measures, and that MAC audit findings, they could lead to costly impact for SNF communities. So making sure all of our ducks are in a row, so to speak, before October 1st is super important. Well, we have reviewed a lot of details today with a lot of information to digest, but with the focus and attention over the next few months, I'm certain that everyone will get the hang of the new MDS changes that are coming our way. Well, I'd like to thank everyone for listening in to hear our discussion on the topic of MDS changes coming on October 1st. And we look forward to having you tune in again for our next episode of Coffee Talk with Encore.